Hello, I'm Dr. Hee-Je Kim from the Catholic Hematology Hospital, Seoul St. Mary's Hospital, the Catholic University of Korea, Seoul, Korea. It is my pleasure to summarize the results on abstract of President's Symposium at EHA 2022, titled Quizartinib Prolonged Survival versus Placebo plus Intensive Induction and Consolidation Therapy, followed by single-agent continuation in patients ages 18 to 75 years with newly diagnosed FLT3 positive AML. It is so-called a QuANTUM-First trial. QuANTUM-First stands for the quizartinib advancement into the next generation of trials for unmet needs in AML first line. As you know well, the quizartinib is a FLT3 inhibitor studied for patients with relapsed refractory FLT3 mutated AML as presented in QuANTUM-R study before, but it was not approved due to several weak points in the results from the previous study. That is, includes QT prolongation as a dose-limiting toxicity greater than grade 3 in 26% versus comparable 6% in quizartinib arm. As far as we know, quizartinib is just permitted to use in limited regions such as Japan from year 2019. Notwithstanding the disappointing data, some quite interesting results were noted through the QuANTUM-R trial, in which patients were randomized 2-to-1 to quizartinib or standard salvage chemotherapy arm. The overall survival was 6.2 versus 4.7 months. The p-value was 0.02. 1 year overall survival 27% versus 20%. Interestingly, the CR/CRh rate was significantly higher in the quizartinib group as 48% as compared with that in the standard salvage chemo group of 27%. The p-value was 0.0001. The median time to first CR/CRh in the quizartinib group was 4.9 weeks, very fast, and the median duration of CR/CRh was 12.1 weeks, suggesting that the patient in the quizartinib group may reach CR/CRh earlier than those in the quizartinib group, as shown in ADMIRAL trial. In contrast, approval of quizartinib for relapsed refractory FLT3 mutant positive AML was based on results from the phase 3 ADMIRAL trial, and we learned the long-term maintenance effects and follow-up adverse events from a post-hoc analysis of the ADMIRAL trial performed 2 years after the primary analysis published in Blood just this year. As an overview, as well as consecutive comparison, other patients enrolled to the phase 3 QuANTUM-R trial had relapsed refractory AML after first-line chemotherapy and the FLT3-ITD mutation at the time of study entry. And this QuANTUM-First trial in EHA 2022 as the pivotal phase 3 study tried to evaluate the quizartinib for the treatment of patients with newly diagnosed FLT3-ITD positive AML. In comparison, the historical first landmark trial RATIFY study revealed that the addition of midostaurin to conventional induction and consolidation chemotherapies for FLT3 mutant positive AML improved overall survival. However, we noticed that there were several points to be overcome for many more tough cases for AML in clinic. Based on the RATIFY study, we are on the consensus to treat younger ages, newly diagnosed FLT3 mutant AML with midostaurin. However, there should still remain a high rate of relapse with uncertain indications for elderly greater than 60 years old AML. These limitations were due to the characteristics of midostaurin's activity as a type 1 FLT3 multi-kinase inhibitor, and the trial enrolled patients with either ITD or TKD mutations. Most of all, the RATIFY trial only enrolled patients up to age 59, and continuation therapy was allowed for up to 1 year. Further, it was not designed to follow up after allotransplantation, although a recent post-hoc analysis showed that the relapse preventative effect of midostaurin thereafter. So there are many more questions for treating FLT3 mutant positive AML up to date, including one is FLT3 inhibitors are truly available for patient either monotherapy or in combination with such as hypomethylating agents or low-dose LRC and other first-in-class agents introduced so far. And second question is it recommended as maintenance therapy after chemotherapy and or transplantation by enhancing not only the anti-leukemia effect, but also the graft versus leukemia effect? And lastly, what exact schedules, such as optimal time starting point, as well as doses and various combinatorial choices will be effective and safe as both a frontline and first salvage option for FLT3 mutant positive AML patients? To answer these questions, we should be focused on most recent prospective studies, and one of them is QuANTUM-First trial. QuANTUM-First is the first randomized study to evaluate the efficacy and safety of a specific FLT3 inhibitor in adult patients with FLT3-ITD AML up to age 75 and assess up to 3 years of continuous therapy, including some after allotransplantation. As a starting point of this unleashed N, through this international phase 3 double-blind controlled study, eligible patients randomized 1-to-1 ratio on day 7 to receive either quizartinib or placebo or orally once daily. Patients began 3-7 or 7-3 induction chemotherapy while FLT3-ITD screening by PCR was performed, and quizartinib was administered from days 8 to 21 in each cycle. The induction period could include up to 2 cycles. A total of 3,468 patients were screened, and finally 539 were randomized in a 1-to-1 manner to receive either quizartinib. 268 patients enrolled, and or placebo, 271 patients enrolled. The most common reason for screen failure was FLT3-ITD negativity, and the median follow-up duration was 39 months. The median age of patient in each arm was 56 years, with approximately 40% of greater than 60 years old patients. Since midostaurin became available in North America during enrollment, the majority of patients accrual occurred in Europe, Asia, and other regions. In detail, 116 patients entered continuation with single-agent quizartinib, and the median number of cycles of continuation was 16. In comparison, 92 patients entered continuation with single-agent placebo, and the median number of cycles of continuation was 17. As presented in EHA 2022, 32 patients and 26 patients were ongoing with study treatment with quizartinib versus placebo arm, respectively. Also, 88 patients and 77 patients are still alive with continuing follow-up for each arm. The primary endpoint was achieved, and results show that the addition of quizartinib provided a clinically meaningful and statistically significant improvement in overall survival compared with standard induction and consolidation therapy alone. Most of the remarkable findings in the QuANTUM-First trial include in a sensitivity analysis in which all treated patients were censored at the time of all allotransplantation, they observed a hazard ratio of 0.752, consistent with the primary analysis. One of secondary endpoint, event-free survival in pre-specified sensitivity analysis without the 42-day requirement or including patients with CRI, event-free survival was longer with quizartinib than placebo. The p-value was 0.0031. Although the rates of CR and CRC were similar or statistically not significant between arms, the duration of CR was approximately 3 times longer with quizartinib, with a median of 38.6 months for quizartinib compared to 12.4 months for placebo. In addition, in a pre-specified exploratory analysis, the median relapse-free survival was 39.3 months versus 13.6 months with a hazard ratio of 0.613, much longer in the quizartinib than the placebo arm. The cumulative incidence relapse at 24 months was 31.2% for quizartinib compared with 43.3% in placebo, indicating that the QuANTUM-First regimen may be able to prevent relapse compared to chemotherapy and surveillance alone. Finally, the occurrence of treatment emergent adverse event during the induction phase was similar, and the rate of greater than grade 3 neutropenic fever did not differ with quizartinib treatment. However, TAEs associated with those modifications and serious adverse events were more frequent with quizartinib. Infection and cytopenia were the most common serious adverse events, and TAEs associated with study drug continuation. Especially cytopenias and hypokalemia were the most common grade 3 or higher adverse events. The rate of febrile neutropenia were similar in both arms. Specifically, during the continuation phase, greater than grade 3 pneumonia occurred at a higher rate in the quizartinib arm, that is 6.9%, compared with the placebo arm, 0%. As previously reported through the QuANTUM-R trial, QT prolongation occurred more frequently with the quizartinib than placebo. Most cases were mild or moderate and were manageable with quizartinib dose modification and correction of additional risk factors. QT prolongation greater than 500 milliseconds occurred in 2.3% of patients treated with quizartinib and 0.7% of patients treated with placebo. There were no cases torso depart. Conclusively, in this pivotal phase 3 trial, QuANTUM-First quizartinib improved overall survival when combined with standard induction and consolidation therapy, and continued for up to 3 years as a single agent in patients ages 18 to 75 with newly diagnosed FLT3-ITD positive AML. The clinically meaningful improvement in relapse-free survival, reduced cumulative incidence relapse, and longer duration of CR appear to underpin the OS benefit. Safety of quizartinib combined with intensive chemotherapy as continued monotherapy was generally manageable with no new safety signals. These data have the potential to change the standard of care for the treatment of adult patients with newly diagnosed FLT3-ITD AML. So, taken all, we are expecting to see the next promising results for our patients who are desperately in need of novel treatment options in real clinic in near future. Thank you for your attention.